you.
Thank you for joining us today for the first session in our 2023 Executive Forum series. This is actually our third session. We started in January, but our first two sessions are available to members as recorded events on our website. We will get started shortly. Welcome, everyone. I'm Denny Brennan, the Executive Director and Chief Executive Officer of the Massachusetts Health Data Consortium. I am excited to welcome you to the third session in our 2023 Executive Forum series, What is Interoperability? Before we introduce you to our forum co-chairs and guest experts, let me go over a couple of housekeeping items. Today's session will be an hour in length, but MHDC staff will stay for an additional 30 minutes afterward to continue the discussion or answer additional questions. We expect participant engagement. This is not a webinar, but a forum. And we plan to be ruthlessly focused because we are only an hour in duration. We prefer you to share your questions or thoughts verbally, as we want this to be a discussion rather than a presentation. Please speak up as we go or use the raise hand icon. I may even call on some folks to share their thoughts, so thank you in advance for your active participation. This meeting will be recorded and will be available on our website within a day, but for members only. The forum series is only for MHDC members, but we offer a $399 non-member rate for folks wishing to attend the forum series without becoming members of MHDC. Following today's session, a Zoom survey will pop up as you exit the meeting. We appreciate your taking the time to provide feedback so we can make the next session even better. So let me introduce one of our two co-chairs for the 2023 Executive Forum Series, MHDC board member, Bill Young. Bill?
Good morning, everyone. David was not able to make it today, but I'm happy to represent Denny and the co-chairs. Delighted to continue this long-standing forum with a new focus on broadening our community, engaging industry and government leaders, and providing dynamic educational experiences for our members. This new executive forum offers high-level view of interoperability from its regulatory, technical, and industrial roots to essential components and features. Our monthly forum sessions feature experts from government, industry, and MHDC membership who help facilitate discussion and highlight key takeaways on each topic. I look forward to seeing you throughout 2023 and hope that those of you who are not MHDC members will consider joining our consortium. Back to you, Denny.
Thank you, Bill. Today's guests are Anna Hyde and Dr. Mark Friedberg. Anna Hyde is the Anna Hyde is the Vice President of Advocacy and Access at the Arthritis Foundation. She oversees both the federal and state legislative programs in addition to grassroots engagement. Her focus is to raise the visibility of arthritis as a public health priority, build support for federal and state legislation that ensures access to affordable, high-quality healthcare, and enhance patient engagement in the policymaking process. Dr. Mark Friedberg is Senior Vice President, Performance Management and Improvement at Blue Cross Blue Shield of Massachusetts. He is responsible for measuring and improving the performance of Blue Cross Blue Shield's provider network, including overall and equity-focused metrics used in value-based contracts such as the Alternative Quality Contract. Additionally, Mark oversees data analytics related to BCBSMA's own performance as a health plan. Dr. Friedberg is a general internist who provides primary care at the Brigham and Women's Hospital. We have 4 questions to frame our discussion today, and this will provide you a brief description of how the forum works. For the remainder of the hour, we want to start with Mark, Anna, providing us with your introductory perspectives on the following 4 questions. 1, what workflows or use cases do you think will benefit the most from increased data standardization and better data exchange? 2, how does standardizing and exchanging data enhance projects around health equity and patient experience? What data is important to include and who should be exchanging it? 3, how can providers, payers, third-party app developers, and other interested parties best work together to improve health equity and the patient experience? And lastly, number 4, are there specific programs or projects you've worked on that you think best exemplify the benefits of better interoperability or that would benefit the most from improved data standardization and exchange? So, Anna, starting with you, let's go with question number 1. What workflows or use cases do you think will benefit the most from increased data standardization and better data exchange?
Well, first of all, thank you for having me. It's a pleasure to be here. I represent the patient community, so I'm going to keep my answers to these questions more in that space and kind of represent some of the data points that we've gathered over the past few years that really speak to a lot of these questions. So one thing I'll kind of frame up to start with is over the past 2 years, we've embarked on a project to really understand the patient experience and the challenges within. I feel like a lot of us in healthcare focus on one thing at a time, or we look at things in silos. Sometimes you're kind of forced to, just by the nature of our work and advocacy. We wanted to take a step back and say, okay, let's look at the entire patient experience from diagnosis all the way through to maintenance of treatment, and really try to understand what the challenges truly are, not what we think they are. You know, we talk a lot about out-of-pocket costs and, you know, utilization management and things like that. But let's really ask the questions of the patients. And so we did a big survey. We followed it up with a number of listening sessions. And really what came through loud and clear to me is a lack of just care coordination, which has a few different angles to it. But I think it speaks to this question in particular, because one of the things that came to mind for me when we did both expert interviews and patient interviews was the challenges in data fluidity that happen when you both have a number of providers that you see regularly to manage your care. Everybody uses a different portal. So even that kind of front-facing kind of information, you know, exchange is difficult for patients to manage through. Things that you may not always think about, at least for me, I had a number of aha moments having these conversations with patients. I have 5 different provider portals, therefore I have to remember 5 different passwords every time I just want to log in. You know, those kinds of things that just serve as little by little these barriers that add up to big barriers. And then everybody has different processes, and my doctors don't talk to each other. And some of that may be interoperability related, but some of it is also just, you know, the lack of provider to provider data exchanges as well. I constantly find myself going into X provider and saying, oh, this is what's new in my treatment. And then that provider says, oh, well, why would your provider do that? Why would provider Y do that? Well, I don't know. I'm just the patient. You tell me. You know, it just, they feel like they are increasingly having to sit at the center of the kind of care paradigm in a way that they shouldn't. You know, the patient is expert certainly in their disease and their symptoms, but they're not necessarily clinical experts, and they increasingly find themselves having to kind of quarterback between providers. So kind of setting that up, I think the data exchange that can happen among all of the providers that treat a particular patient, And then standardization certainly of some of the utilization management protocols that people with chronic disease particularly experience. Prior authorization is one of them. Certainly over time, many patients with, who rely on maintenance of treatment, we're talking about a lifetime here, having to go through prior authorization continuously, having a more standardized way for that to occur, and for the patient to be aware of what's going on at what point in the process. I think that it's underappreciated how much of the burden falls on the patient. I think that providers often feel like the majority of the burden falls on them. A lot of payers are feeling like they're spending a lot of time on the phone between different stakeholders. I think people underappreciate the fact that the patient is often the true go-between, having to go from the provider to the payer or the PBM and triangulate. It takes an enormous amount of time, oftentimes, and I may be getting ahead of myself here, so I will say this and then I will stop. The proposed rule right now on prior authorization, the patient-facing API, the payer-to-payer, and the provider-to-provider really, I think, can solve a lot of what I'm talking about here. So in terms of kind of solutions that will benefit, I think that's really one that we're optimistic about.
Terrific, thank you. Mark, from your perspective, what workflows or use cases do you think will benefit the most from increased data standardization and better data exchange?
Yeah, thank you, Denny. And I just want to say it's a pleasure to be here. And I want to say, first off, I agree with everything Anna just said. I'm going to double down on a lot of that. Just putting on my clinician hat, the lack of seamless ability to see information and results across health systems, especially from our more complex patients who do have providers in many different EHRs and EHR instances, is a major contributor to unsafe and substandard or suboptimal care, I would say, as well as professional burnout. The amount of time I and other clinicians spend just chasing down other records still and looking at like scans of records in PDFs, which is insane to me, that it doesn't show up. Like if I want to see a lab, it doesn't show up in my lab interface. I have to go find it somewhere else. Same thing with sleep studies and you name it. There's a ton of these little things you have to deal with. Is really a huge opportunity for improvement. Also, and I'm not going to spend too much time talking about this, but on the point about prior auth, I couldn't agree more. Blue Cross Blue Shield of Massachusetts has actually put a major strategic focus into automating prior authorization. We had a successful pilot on that with an orthopedic practice earlier this year. And the amount of inefficiency that could be removed from the system in that critical aspect of health plan operations is considerable. I think that'll be appreciated by everybody concerned. So on to my area of focus in my role at Blue Cross is around quality and equity measurement. We are with NCQA and other measurement entities, both nationally and locally, working on a transition from one highly structured, well-developed set of data, but which is imperfect, which is billing data. The reason HEDIS measures have historically been based on claims data is that it's a standard format that everybody uses. The ICD-10 codes are the same. The procedural codes, the HCPCS codes, all the same, quite standard. To something that's really decidedly not very standard so far, which is the electronic versions of those measures and the digital versions of those measures. That transition, I think, will be only possible with two things in place. The first is a much more well specified set of electronic data elements. And the second is unfettered access to those data elements between payers, providers, and other entities, all of whom I believe currently have technically legislated access to that, but we don't actually have access yet in reality. So that will be a major challenge in the coming years. But I think if we have those two things, we'll be able to make a huge improvement in what we're able to measure in quality of care. and start to get into, I would say, long neglected areas of quality, which are currently mainly in registries, such as quality of specialty care and chronic conditions outside the primary care realm, where we tend to focus almost exclusively on diabetes, high blood pressure, and depression. On equity, there's another layer, which I would say is just a special case of the transition from claims data to electronic health record data, which is the stratification variables for equity measures. So we've been focusing pretty hard for the last couple of years on stratifying our quality measures by member race and ethnicity. But that's just a starting point. There's many other ways we could stratify data to assess the equity of health and healthcare that our members receive. That would include language, sexual orientation, gender identity, disability status, national origin, and many other variables. All of those have not been part historically of billing data. So they were not collected in a standard way in general. We're just working with our provider network now on getting standardized. I would say some of our providers in Massachusetts are quite far along on that. Others are, at an earlier stage of such things as understanding what data standards their own race and ethnicity data are on, assessing for the first time the completeness and accuracy of those race and ethnicity data, and being able to exchange those race and ethnicity data internally, let alone with us. So these are critical underlying measurement issues that we need to have, I think, in place so that we can assess the effectiveness of our equity improvement activities. We are not in the business, at least in our health plan, of creating the appearance of doing something about equity without knowing whether it actually worked. And we need these measures in place. So we are prioritizing that quite heavily and working with our provider network on that. Thank you.
Thank you, Mark. And thank you, Anna. I'm going to turn now to our second co-chair, David Carusio from Point 32 Health. David, would you introduce yourself and shed a little light on your experience or insights into standardization and better data exchange for your organization? If you're able to unmute yourself. Perhaps David is not on the line at the moment. Well, let me turn it to members of our audience and ask folks to unmute your mics and provide what you think are some of your perspectives on this particular question. Any comments from people in our audience?
Hi, Denny, this is Janice. I'll get things started with a question for Anna. I wanted to get your perspective on the patient impact of excluding all medications from the prior authorization components of the CMS proposed rule.
Oh gosh, I feel like that's such a gimme question. I'll just say this. I'm in the process of writing our comments as we speak, and I think I say no fewer than 6 times that medications should be included, if not in this, then in immediate future rulemaking. Because I mean, for a lot of chronic disease patients, particularly in my therapeutic space, prescription drugs is where they see the challenge. Not that there aren't, services and procedures and things like that they can experience challenges with prior auth as well. But prescription drugs tend to be, at least for people with inflammatory forms of the disease, that is where the maintenance of treatment is. It's in prescription drugs. And I would argue that the current kind of standards and processes in place around prior auth for prescription drugs are not adequate to address the challenges and the things that are the objectives within the proposed rule. I mean, I think that as CMS lays out very well what the challenges are for patients and providers, and I feel like it's a real missed opportunity to not address prescription drugs there.
Thank you. Why don't we move on to our next question? Or Bill, you've come online. Do you have a question?
It was more a thought kind of related to this topic, and just one that as a provider of care, Behavioral health and substance abuse, right? The sharing of that data is very secured and hard. And, you know, we're finding that many of our critical patients in my world, right, may have multiple comorbidities that really relate to how we care for them. And what we're finding is the locking down of some data and the need to kind of maybe share that. Mark or Anna, do you have any other thoughts on that one? The behavioral substance abuse kind of folks out there that we do want to protect their data, but the importance of sharing it.
Yeah, I have a lot to say on this topic, and this actually comes from my clinician hat and also from some work I did in my prior role at the RAND Corporation as a health services researcher. And I'll put into the chat a paper that we wrote from some research around behavioral health integration. It turns out that one of the main impediments, and this won't surprise any clinicians on the line, to behavioral health integration is this issue of access to behavioral health clinical data. It has to do with massive over-interpretations of federal regulations. It's a little bit like HIPAA, you know, it becomes this convenient excuse to never give anybody any kind of data, even though that's not what HIPAA says. The same thing is happening with behavioral health specific regulations being over-interpreted. And even, you know, such things as break the glass alerts in, let's say, an Epic instance are a huge, I would say, nudge away from anybody on the care team being fully aware of the clinical important factors for a given patient. I mean, just to give you an example of how ridiculous this is in my own clinic, I will I'm a primary care doc. I need to know every last thing about work notes from my own clinic without going through a break the glass alert. And it really makes me sometimes not look at them because I'm worried that somebody somewhere is going to get me if I attest to looking at this when the system should already know I'm that patient's PCP. There's no reason whatsoever to have a break the glass alert in place for patients for whom I'm the PCP. Worse than that, and this actually occurs quite a bit in a lot of health systems, is behavioral health clinicians suppressing from the record completely any evidence of behavioral health services being rendered. So this means not only are there notes that have a break the glass alert, but the notes don't even appear in my view of the record. I've had this have untreated behavioral health conditions and come to find out that no, they are being treated, but the whole thing is secret from me, the PCP, which is professionally incredibly insulting and does limit the quality of care that I can render, unfortunately. And I would say this is not a technical issue. This is a cultural issue and an organizational policy issue.
Certainly, and we can't really talk about data and standardization and exchange without understanding those underlying issues. And I appreciate your perspective on that. Leslie Reef from Fallon Health, you've raised your hand. What question do you have?
Hi, thanks, Denny. I just wanted to thank Mark for recognizing and articulating how difficult it is to get a data exchange going between partners. Fallon Health is embracing the digital quality measures, but we are having trouble getting feeds from our partners. And, you know, we really are struggling in this area and would like to get more data. So thank you for recognizing that it is a challenge, not just for us.
Thank you, Leslie. Why don't we move to our next question? Question number 2. How does standardizing and exchanging data enhance projects around equity and patient experience? What data is important to include and who should be exchanging it? Mark, I'll start with you on this, and then Anna, I'll follow up with you.
Thanks, Denny. And sorry, my Zoom skipped out there for a second, so I think I got in right when you were asking the question. So I think I'll just say something brief to build on what I said on the previous question, which is for standardizing and exchanging data to enable health equity to move forward, we need those stratification variables. That's the key thing. In addition to everything else, it's the race, ethnicity, gender identity, sexual orientation, and so forth. That's absolutely critical. And I would say we are farther along with race and ethnicity because there is a mature FHIR standard. I know that's going to be revisited with the current administration looking at the OMB 1997 standards, and that's I think a really welcome update, especially to those minimum data elements. And we'll be ready to work with whatever comes out of that process. But we're not as far along with everything else. So sexual orientation, gender identity, and language are not quite as mature in terms of the FHIR standard, and that's important for us to have, because our worry is always that we're going to have multiple data source standards. We may have a federal standard, a state standard, and we have different standards that different providers are using that works against making progress on equity. The other data element that I would add that we don't have a national standard on that we sorely need is data provenance for these equity variables. What I mean by that is just taking the example of race and ethnicity. We might receive from any external source, whether it's a government source or a provider source, a file of race and ethnicity values for our members, but we don't know, and they don't know, the source doesn't know, the source, where those variables, those values actually came from. Whether they were from a survey, using best practices and self-report in a voluntary way from the patient, or whether it was through spoken word, maybe with sometimes the training isn't so great on that, or it can be unevenly applied, or it can be not even asked at all. There's a substantial amount of observed data on race and ethnicity in EHRs that is intermixed with everything else and unlabeled. And that really hampers our ability to assess the accuracy of data, because when we do receive data where we don't have these kinds of provenance codes assigned, we might find, and we do find this pretty commonly, like the external data source is missing a third of our Hispanic members who have self-identified to us using best practices that yes, they do self-identify as having Hispanic ethnicity. We don't know why that's the case. It could be that the data collection, what we're seeing there is really the mix of observed and best practice data collection by the counterparty. So that's another area of major opportunity. Thanks.
Thank you, Mark. Anna, what about from your perspective?
Oh gosh, well, I think Mark hit on a lot of what we have found as well in some of our research, that just collecting the data and the right data in the first place is so important. And then what do you do with it? To what end are you collecting the data? There are, in the work that we've done in recent history, there are a couple of areas where we've seen particular challenges around health equity. One is around socioeconomic disparities. Of course, there's a correlation. I think there are copious amounts of research that back this up around socioeconomic status and treatment adherence. Certainly in our therapeutic area, where maintenance of treatment for rheumatoid arthritis, for example, requires consistent access to high-cost drugs. That is just the reality. Biologic medications, specialty medications are expensive. And there is, our ultimate goal is to make sure patients have what they need to stay adherent to the medication. And that is a very nuanced and tricky question. There are so many factors that go into that. But we do know that that is a major one. So that's one kind of piece. Another piece that's interesting, when we polled a lot of patients in our focus groups, the first question we asked was, how would you rate your experience of care, right, or coverage right now on a scale of 1 to 5? And the real discrepancy between people who had a better experience of care and those who had really not great, we'll say, experience of care was people who live in rural areas and don't have steady access to providers. And so I would definitely, for us, the kind of the collecting better data so that you can more precisely target resources to address health equity and all of the facets that lie within, but then also the kind of health disparities that come from that kind of rural urban divide. Not that there aren't disparities in the urban in terms of access to providers in the urban setting. There are a whole host of challenges that patients experience there as well. But the people who live in rural areas and don't have steady access to providers, and as I mentioned before, when you're experiencing a chronic disease like arthritis, it's very unlikely that you are only relying on one provider. you've got your primary care, you've got your rheumatologist, you've got perhaps a physical therapist. You probably have comorbidities of some sort. Diabetes is a high one. You really need a care team, and the access issues that happen as a result have a profound impact on the patient experience of care, which then of course has a profound impact on treatment adherence, on quality of care, on outcomes, et cetera. So I would be remiss to not mention that. And then one final thing on telehealth in particular. I think telehealth has been propped up since the pandemic as a real boon to addressing some of those disparities. And that is true. And we've had a lot of positive feedback from patients on the ability to do telehealth, even those in urban areas. You are experiencing a flare. Even if your healthcare provider is 10 blocks away, it can be very difficult for you to get from point A to point B when you're not feeling well. I think that can be underappreciated. The ability to do telehealth can be really helpful. However, what we have also heard, particularly in talking to patients of color, is that it can exacerbate disparities as well, because cultural competency is, of course, a major component to having a good experience of care in the exam room, and that the interaction that happens in person goes a long way towards that trust and relationship building that happens between the patient and the provider. And what some patients have told us is that, and this is purely anecdotal, is that when you remove that in person and you're putting a screen between us, you're adding a barrier that makes it harder to build that relationship with the provider. So telehealth can kind of cut both ways. And I want to mention that as well, because I think a lot of times, at least lately, people talk about telehealth as this wonderful benefit, but there's this other side that needs to be taken into account as well.
Thank you. Let us turn to our audience, the forum. Any questions or comments from our group?
Hi, this is Janice again, if no one else wants to take the opportunity. Mark, I was curious if you had any thoughts on, you mentioned better data collection, more consistent data collection, and we are completely on board with that. That is more or less our main mission in life. But do you have any thoughts on some of the changes that are undergoing the industry? For example, a decision to look to USCDI as the main national way to define what clinical data is necessary for the majority of cases, changes to OMB standards, some of those things. I was curious if you had any sort of high-level thoughts on that bolus of attack.
Yeah, it's a big question. So I'll just maybe focus on the question about the changing of the OMB standards for race and ethnicity, because that's probably what I'm paying the most attention to currently. There's a tension there, which is the current standard has been in place for over 25 years. The OMB 1997 standard, which is the 5+2, 5 racial categories, 2 ethnicities collected separately. And the FHIR standard is built from that. FHIR level 1 is OMB 1997. So when that changes, that's going to require changes to a lot of legacy systems, which is going to be rough for everybody to some extent. But it's also going to render some past data potentially, depending on how this is done, not easily translatable over to the new standard, and all of that will have to be recollected. And will also require retraining of imputation models for missing data. It's best statistical practice to always impute your missing data. You never want to do a complete case analysis for this or anything else where you have missing data that are not missing completely at random. And all of those models will have to be retrained. So my hope is that the new standard does not, it meets the needs of, I think, evolving, what's the right word here? Evolving sensibilities around race and ethnicity nationally, especially around the way categories rolled up, without requiring a ripping out of the entire wiring and starting from scratch. That's the balance here.
Thank you, Mark. Why don't we move on to question number 3? Question number 3 asks, how can providers, payers, third-party app developers, and other interested parties best work together to improve health equity in the patient experience? Anna, I'm going to start with you on this question.
I would go back to a point I made in the first question, which is that there are so many platforms. You know, think about from the patient perspective, you probably have a portal or an app through your payer. You have one for each provider that you see. And then any third-party app, you know, there are so many digital apps that are marketed to patients, and particularly having to do with lifestyle interventions to manage your disease, which hits front and center for people with arthritis. So how do you keep track of all of that? I think in terms of the patient experience piece of this, most certainly finding a way to make it more seamless for patients to travel between all of those things is really critical. The other thing I think that's really important is taking data from apps that patients are using to manage their symptoms and rolling that in whatever way is most appropriate into the EHR is really important. I think we have more remote therapeutic monitoring that happens now in arthritis. I'm sure that's true in other therapeutic areas as well. There are all of these ways to help patients manage their symptoms in between visits. I think that's the key. There's a lot that happens, of course, in managing patient care in the exam room, but a patient is spending a lot more time managing their own symptoms outside of the exam room than they are inside it. And so how do you collect that data and make sure that it all rolls up in a way that the provider, the care team is able to look at it and get a more holistic picture of the patient? I think that's the goal that we're really moving towards. And I think that that gets a lot of the health equity piece of this as well.
Thank you. Mark, what is your perspective on providers, payers, third-party app developers working together to improve health equity?
Yeah, I think improving health equity is a huge challenge, and all of us are going to have to work together. So we have focused at Blue Cross Blue Shield of Massachusetts, pretty heavily on our provider network in state as partners in moving forward on health equity. It's not the only strategy we're pursuing, but it's the main one currently. Regarding third-party app developers, I think there's certainly going to be a role there. I'll just say one note of caution around third-party apps that we spent a lot of time thinking about in the context of health plan interoperability regulations that went live in the summer of 2021 is that it's, I think, unclear to a lot of our members, patients, that when they share data with a third-party app, that can be a huge end run around legal privacy protections. So these are apps that are not subject to HIPAA, and that means that you don't have legal protections against the app doing all kinds of things patients may not realize the app could do, such as selling the data, including all of it, really, including confidential health records. All the way from behavioral health conditions to HIV status, all of that, once it's over the line over to an app, could end up anywhere. And it's not just you, it's your family, your kids, your parents, anyone you're related to in the age of DNA analysis and that kind of forensic work being commercially available. Their health information is compromised by your one decision. So we spent a lot of time thinking about how to try to explain this to our members and get them to think more carefully about that initial sharing, which can never be undone with a third-party app in many cases, as compared to other terms of service that we're all used to seeing on the internet and just clicking through without reading.
Thank you. True, those terms of service are daunting enough for us to simply accept them as they are. Chris Matarazzo, you've raised your hand. What question do you have for us today? You're probably on mute, Chris. Let's see. All right, why don't we move on to other questions we have? Janice, I believe you have a question.
Yes, but I would like to encourage other people to speak up as well. But my question is going back, Mark, your comments about the privacy issues, which are well discussed. Do you think there are specific things that the FTC should do to improve privacy of third-party health applications, or to improve comfort levels and education around that?
I think they should do something. I don't know what to do specifically about it, but it's just first an acknowledgement of the problem. I think is absolutely critical. These are decisions that can't be undone. This is really important for people to understand. Without expanding HIPAA to cover every app developer out there, I think that might not be possible, but that would be one way of approaching this. Another way is to engage in some kind of massive public education campaign. I don't know how successful that'll be either, but it's we've blown a huge hole in HIPAA with the health plan interoperability regulations that currently apply to us. And no matter how much we warn our members, we are not allowed in a member's best interest to tell an app no. We won't turn over all of the data that we're required to turn over if a member requests it.
All right, we have some Q&A, folks. Raj, you had a comment. Would you like to share that with us as a group and have our panelists speak to that?
Sorry.
Perhaps,
sorry,
let's see.
Mute. Can you hear me?
There you are, Raj. Yes, we can.
Sorry, I was on mute. Raj Bosnumat from Point 32 Health. I just see a tendency to look at interoperability as another compliance bullet to dodge. If we can come out of that and look at it as in our own long-term interests and will benefit our bottom line in the long term, that will go a long way in embracing interoperability.
Thank you for that comment. Janice, you had a comment or question to raise.
Yes, I just want to follow up on what Mark said, because I think while I understand that the people who work in healthcare think of HIPAA as a be-all end-all thing, and maybe Anna can address this part of it. I feel like for patients, a lot of patients don't understand what it brings, and they don't really see that distinction. But there are other areas of life where there are extreme privacy concerns, such as, for instance, financial components, and there isn't this overwhelming concern because that industry has protections and protocols in place, and they're not through HIPAA, and they're overseen to some extent by the FTC. So there's a similar level of the way that this works. So I guess I'm just wondering if maybe Anna can comment from the patient perspective. Obviously everyone's concerned about privacy, but is this divide that's there from the healthcare perspective of it's in HIPAA, therefore it's good, and it's out of HIPAA, therefore it's probably dangerous? And I realize I'm oversimplifying that, or it might be more dangerous, something that patients are talking about.
That the vast majority of patients don't understand all the nuances around HIPAA. So that's, I think, the first thing. I also think that what Mark was talking about, it's sort of how to educate members, patients about kind of what privacy protections mean inside and outside of HIPAA. Like what does that really mean? Is incredibly important, also incredibly tricky, because the terms and conditions apply across so many aspects of healthcare. And as a patient, a chronic disease patient, you're managing so many layers. And so where does this fit into the paradigm of what I have to understand? Also, I don't feel well, I am sick. And so I'm just trying to get to the right treatment in the first place. And I'm trying to get through all of these roadblocks that are in front of me just to get, to get the care that I need. And then you're going to layer this on top. So I I would encourage anyone who's working in healthcare to think that way of how much is already on the patient. And so where does this fit and how do you make sure that it is that the education around it is as seamless as possible? Where should that conversation take place? I think the provider's office is the provider is the place that the patient most often looks to for trusted information. It's the point of contact that they have the most. It's even though we know providers are limited in the amount of time they can spend with patients, it's still the place that they have the most interaction and can have the most dynamic conversations. So I would sort of think that way about it as well. Although we also understand that the providers don't necessarily have 100% line of sight into all of the apps and all of the things that patients are using. So that's another kind of challenge. The just general conversation around privacy and patient data is one that we're grappling with at the moment as an organization, and kind of where we want to spend our time in that space. A lot of those apps I mentioned that patients are being marketed to around managing their disease. I mean, how valid are those? You know, what is happening to the patient's data if they're utilizing those apps? There are a lot of landmines there that we're starting to explore a little bit more. But I also think, you know, in our historical, even in surveys that we do, we ask patients for a lot of intimate information about their health status. Even there, you know, one of the pieces of feedback that we consistently get is, where's my data going? Where is it being used? I think patients want to know how it's being utilized. Is it being utilized for good? And is it going to come back to me to improve my own understanding of my care, right? So that feedback loop is really important. That's another thing that I think needs to be part of the conversation is what is the feedback loop? What is coming back to the patient?
Thank you, Anna. Mark, you're nodding to what Anna is saying. Any comments from you on this?
I think that the point about making it clear to patients how their data will be used is absolutely critical. We found that even for questions as simple as, you know, please indicate your race and ethnicity. We include an explanation for why we're asking. And this comes from some market research we did and just recently repeated that shows that most people don't think of their health plan as having any role in health equity. So why would you ask? Or first off, they ask, well, don't you already know? We don't. That's a surprise to most people. Second is, why are you even asking? Why does this, you know, and then we do have to, you know, we spent a lot of time getting that language down, where we have a pretty successful survey response rate, which is that we allow the data to be used for two purposes. One is to measure inequities in care, and the other is to do something about those inequities and try to make them better. And that's it. We don't allow any other use of the data. But the other piece here, of course, getting back to the app issue is, as much as people may understand, I hope what's being intended to be used with their data. There's always a question of enforcement. Once you're outside HIPAA, you know, what's your legal remedy if the company lied or changed its mind or got acquired and that new owner got the data and did something else with it? I think there's that's where we're gonna we have a major challenge.
Okay, thank you. Thank you for the questions too. Let's move on to question number 4. Question number 4 asks us, are there specific programs or projects you've worked on that you think best exemplify the benefits of better interoperability, or that would benefit the most from improved data standardization and exchange? Anna, why don't I start with you?
So my answer is going to be very 10,000 foot, and I'm sure Mark is going to bring us down to ground level. But the program that I started with, I didn't mention the name of it, but just this undertaking to really understand patient challenges from kind of start to finish of their disease journey. The name of it is called Ideal Model of Care. So I would point to that as just a way to kind of understand the patient challenge, and then obviously to pinpoint, okay, what solutions need to be put in place. So that's kind of where we are right now, having undertaken that work to really kind of understand the top focus areas. And interestingly, as we tried to undertake this project from the beginning without any preconception about what patients were going to say, which is very difficult. But again, not making presumptions about, oh, of course it's going to be out of pocket costs. Of course it's going to be step therapy, these things that we spend a lot of time thinking about and talking about. And it wasn't necessarily. And I would go back to the care coordination as one of the core areas that we heard the most from patients as being kind of an overarching challenge to just managing their healthcare. So that certainly is a place where better interoperability, I think, could benefit in the data standardization around, prior auth, and really, how to file an appeal and what that process looks like, and how clear is it to the patient. Just all of those kind of aspects of managing their health coverage are really vitally important to improving the experience of care. And one of the themes that we really honed in on as we were going through this process was technology as a solution. And certainly there's these components of making the interoperability happen, making the data exchange happen, the standards that need to be put in place to do that. And then from there, okay, now we can more precisely target, groups of patients who have higher levels of needs for one reason or another. We can more precisely tailor treatment options. We are taking some of the clutter away so that we can then really focus on better patient care and moving towards better patient outcomes. The one thing I would say as kind of a final pitch is that all of this should be done with meaningful patient engagement. So you're developing standards, you're developing apps, you're developing patient education materials, whatever it is that you're developing, are you doing it with patients at the table, helping to vet the processes that you're embarking upon? We talk about patient-centered care and the patient being at the center and all of these things, but in order to truly do that, you've got to have the patient community in the room as you're developing whatever it is that you're working towards. So I would put that as kind of a final pitch, because if the goal is to do all of these things in order to improve patient care, you've got to have the actual end user, the patient, as part of the process from the beginning. And that's something that we certainly would always put ourselves up as a resource to anyone working in this space.
Thank you. Mark, what about your perspective here?
I think it's going to, from my perspective, it's the ability to more accurately and comprehensively measure the quality and equity of care. And I've been a little less involved, but other parts of the organization have quite a bit of success in interoperability, smoothing the prior auth process.
Thank you. Shira Fisher, you have a question that you wanted to ask. Do you want to unmute your microphone and share that with us?
Sure. Just about patients' ability to withdraw consent. I mean, they agree for care, they agree for HIPAA, for TPO, but if they don't want their data used for research, at least in an identified way, not in an aggregated way, I know that there are at least some local systems that do not give patients that option.
Thank you. Anna or Mark, any comments on this particular issue with respect to information sharing and patient consent?
Sounds important. I was unaware that that was a policy of any provider. That's a little troubling to me.
I agree. I think that would be something that if I were to encounter, I would feel that wasn't the prerogative of the provider to make. But Anna, what about yourself? Any thoughts or any experience in this particular area?
That it's on their consent form for admission, and if you don't want to have your data entered into their EDW and RPDR and all of those things, then you can just not get care there.
Yeah, can I suggest that seems reportable to an institution's IRB and also to the federal agency that accredits IRBs, because that's definitely not informed. That's not consent. That falls into that's almost like doing research. People under duress can't give consent. This is a critical component of research ethics. This is why we don't do research on soldiers, prisoners, and children, and other cases without special protections.
Thank you for that. Let me just first say we're nearing the top of the hour, and I would like to provide folks a little bit of an overview of what's coming up next. So perhaps we can go to the next slide. Our next forum is scheduled for Thursday, April 13th. At this time, our guest experts are Ruby Raley and Marianne Yeager. Ruby is with ASCO, and Marianne is the leader of the Sequoia project, which is responsible for TEFCA. Ruby brings expertise in APIs. Marianne brings expertise in document-related exchange, which is at the core of TEFCA. And this is going to help our members understand more about what the exchange standards are and how they're moving forward. If we move on to the next slide, please. If we have another slide. And I should clarify that Ruby is with Axway, if I mispronounced the organization that she's from. Thank you. Anna and Mark, before we depart, I know we have just 5 minutes before the top of the hour, but are there any final closing comments that you would like to make given the discussion today that our audience can take away from this? Anna, I'll start with you.
Yeah, I would just reiterate what I said at the very end of the last answer, which is that I think meaningful patient engagement needs to be sort of, the patient needs to be looked at as a kind of an equal and meaningful stakeholder as we move towards better systems and processes for data exchange. And I think a lot of, it seems as though everyone has the same objective, but how are we getting from point A to point B? There's just a lot of opportunity at the moment, but within that, there certainly are a lot of potential landmines and pitfalls. I think we've discussed a number of them here. So I would just, encourage anyone here to reach out anytime to myself. And I know that my counterparts at other patient organizations are always eager and happy to participate in bringing the patient perspective as well. And I really appreciate the opportunity to be here today.
Well, thank you. We appreciate having you. Mark, any final comments from you?
Not much other than just to say for providers who we're going to be partnering with on information exchange, we really look forward to getting deeply into that with you in the coming years.
Thank you very much, Ed. With that, I want to thank everyone who participated in today's forum. Mark and Anna, I especially want to thank you for sharing your insights. This is always a great pleasure and privilege at MHDC to hear from experts across the field and gain a broader understanding and appreciation for the challenges, the promises, the pitfalls in health information exchange. And I want to thank you for joining us. Those of you who have joined us today, I want to thank you again and ask that you take a moment to complete the brief survey that will pop up on your screen at the end of this forum. With that, I will say that we're adjourned and we will see everybody next month. Bill, any final comments from you?
I just want to say again, thank you, Anna. Thank you, Mark. Great discussion. Appreciate your time this morning. Great to see everyone out there and look forward to seeing you next month.
And the MHDC
you
folks will stay around for another half hour to continue this conversation.
We will.
And for those of you who are staying, we'd really like to hear your thoughts on programs that would be helpful or that you're doing now.
Thanks, Andrew. Thanks for joining us today. I want to re-ask Janice's question just among those of you who remain. What questions or feedback or comments do you have about today's discussion? Any final parting thoughts, comments? Let's see, I see things coming up on the chat. I see thank yous, and thank you, Shira, for joining us today. All right, so
David, are you really out there? David, are you really out there?
Dave Q.
We had, I think, at one point, 4 of him. So,
There might be multiple people from Point 32 Health participating.
I wonder if they snuck in under David. Yep.
They might have slipped in there and have left their phone on the hook, so to speak, in using old-fashioned parlance here. All right, given that there are no further questions, we will end today's forum. I want to thank everyone for participating. I want to thank our MHDC co-chairs, Billy Young and David Crucio, as well as our team for helping this be as excellent and informative a forum as it was. We'll adjourn and we'll all talk to you soon. Take care.
Thank you, Denny. Thank you, everybody.
Thank you.
bye,
Bye-bye, Bill.
everyone.